I'm here with Dick Wardrop. We're going to talk about medicine. We're going to talk about William Osler, hopefully some philosophy and stoicism, and how it all mixes together for a better life, a leavened life, a life well lived. So I am Michael Stanley. I'm a former Bean Award recipient and a current member of the William Osler Society board for the American Osler Society, and I'm here with Dick.
Thanks for having me. It's a privilege to get a chance to talk with you about all of those things that you mentioned, especially as it relates back to someone who I've referred to in talks I've given is William Osler, who is a friend of mine.
There's actually a wonderful sort of history of books and the man and books and friends. There was a poem actually after Osler passed away about that sort of, these quiet people that we get to go to. They're always ready at the shelf for their advice. Some people call them books, but we call them friends. And you do see that experience at the AOS where people are as enthusiastic talking about the provenance of a book and their relationship with it as they can be with the sort of the person that gave it to them or lent it to them or acquired by other means. So for yourself, if you would just kind of tell us a little bit about your current position and practice right now, that'd be awesome.
Certainly, thank you. So I'm currently at Cleveland Clinic in Cleveland, Ohio, at the main campus. One of my positions is program director for the large internal medicine residency here. I'm also a hospitalist. I spend about 35% of my time in patient care, mostly with medical students and residents at this point in my career. I really cherish the privilege of being able to teach in the clinical setting at the bedside, but I also do a fair amount of, I guess, what you would consider like didactic or classroom or other forms of experiential learning or teaching as well. So I really do embrace the role of a clinician educator or medical educator. I'm also in a leadership position within our academic department of medicine where I serve as vice chair and really enjoy the interaction with the community of educators that we have here at the Cleveland Clinic Lerner College of Medicine, which is actually part of Case Western Reserve. So Case Western Reserve School of Medicine is part of my community as well. And then, of course, the greater Cleveland medical community, which is a very vibrant place to practice medicine.
Now, Cleveland, Ohio, now that I'm thinking about it, that is the source and origin for Harvey Cushing. But I don't think I think he's buried out there. But I actually don't know. Is there much of a Harvey Cushing presence? I mean, is that a thing that gets brought up in Cleveland, or is there a?
Yeah, I do remember some folks reflecting with me on that when I discussed some of the historical things that I was interested in with regards to Osler. But I can't say that I recall that fact, to be honest with you, embarrassingly so. But that has not come up on a regular basis.
He was from that way. I think the family had Eastern ties, and then he spent the rest of his life largely in New England. I think he is buried out there. There's a great photograph of Marty Samuels, actually one of the great neurologists, who was also a Cleveland boy. And if ever something Cushing related came up, there you'd go to the picture of here I am standing next to standing next to Cushing's grave. We've been at where he practices, but this is where he died. But and so on the larger scale, so there's your work that's at the level of Cleveland and the sort of Cleveland area, but in terms of ACP or things beyond that, what's been your involvement in medical education and sort of medical stewardship, I guess, at the national level?
Yeah, thank you for asking. I've taken my professional identity as a medical educator, within the realm of also being a busy practitioner. And I've been very fortunate to be able to explore that in other spaces besides, the daily employment arrangement that I have. Some of my professional homes that I've really enjoyed and actually established some very important longitudinal and I hope lifetime relationships through have included organizations such as the American College of Physicians. Also, I'm also a pediatrician, and the American Academy of Pediatrics is another. More recently, the Society of Hospital Medicine, And all these membership organizations have a lot in common, more in common than they do is different, and that they have, opportunities for niches within medical education, but also understanding the role, the importance of, public accountability. So I've really, within the ACP, for instance, really benefited from a wide variety of experiences, advocacy at the local level, at the state level, certainly advocacy at the national level with ACP through their Leadership Day program. That's been a part of my experience as a medical educator and as a practitioner, quite honestly. And then more recently, really getting involved with the Alliance for Academic Internal Medicine. And then most recently, the American Board of Internal Medicine. I've become a member of the board and will actually be chair of the American Board of Internal Medicine's IM board and a member of the Council of Chairs starting in July. So that is something that is sort of I've experienced, and I've gone through that part of that leadership cycle for the last 4 years on the board, and have just really really benefited from that experience and exposure, and very excited to take that leadership role as well.
I forget who said it, but somebody once said chair is a misnomer. Footstool is more accurate.
Yes, these
But
are these are exciting times to be in that organization, as they all in all organizations, but as physicians of every specialty, sort of look at the value of maintenance of certification and other programs such as that. It's a challenging time, and I think we're going to have some pretty important conversations over the next several years.
Well, so I want to talk with you about that. One of the things that's sort of apparent from the life of Osler, and he wrote and spoke on it, was the role of societies in a medical practitioner's life. That, yes, there's the educational component, but there's the social component. There's even the ethical component of what happens when people from different schools of thought mingle. In neurology, which is where I spend all of my time for the most part, what we've noticed is the various societies which are specialist driven might in some ways you lose them or you dilute people into their subspecialty. They never get to mingle back in general neurology. So these very larger, national organizations are like, well, people come here for some of their CMEs, but otherwise, we're not really sure why they're here. And then the subspecialties, they go, well, they're here for the CMEs, but what can we do if we're so few? So one of the things that came to my mind when I'm listening to you talk about, well, member of this and a member of that, and I chair that, and I'm on the, all the rest is, how do you look at belonging to a society and the work that you put in it? Because I'm sure many people, certainly I was when I was in residency, I think to myself, I go, it's enough just to be in hospital, but to actually have a professional home and try to maintain that, like, why would I ever want to do that? And there are great reasons why you should be committed, if not overly so. So what were some of your reasons?
Yeah, so there is a slogan that we oftentimes say to each other in ACP. Why do people join the ACP and stay in the ACP? It's not just for the fancy letters after their name or the CMEs. They actually, when they come to the meeting, we say that they come for the science, but they stay because of the people. And that is absolutely the experience that I've watched happen over and over again with trainees and students and early career physicians, as they've found their personal and professional home within an organization such as that. So for me, it has less to do with like a value proposition of, what insurance benefit you might get if you join, or what dry cleaning specials you may get if you belong to the local medical society. But I do think that there is something in what Osler used to say, and I can't quote it, but specifically around medical societies and the reasons for joining and for maintaining. I like to go to our state ACP meeting. I sometimes speak at that. I've been in 4 chapters in my professional life, and on our version of the board on each one. But there is a part of me that likes just to go and just be a member and listen to a new update on weight loss agents, or an update in management of ARDS in the ICU. Whatever the topic is, there is a certain satisfaction that I get to my own identity as a physician, as a practicing physician, to become updated and to be up to date through the sharing that I don't necessarily get without being in person. So that may be an old-fashioned view, but I think there's definite value in belonging to a membership. And I will say, despite having been in leadership in a lot of organizations, I do enjoy the followership as well, and being a part of an advocacy movement, and feeling like some small part that I have to play in, like, advocating in Washington, D.C. for, increased GME funding, or when we used to advocate for, removal of the SGR, things of that nature. Everyone has a part to play, and I feel like a lot of these professional organizations that you mentioned have a big role in that, in playing that part outside of our day jobs.
Now that I know where you are, and I know what many different hats you're wearing these days, like, how did it start? What called you into medicine? If you remember the story.
Yeah,
Moment.
there was a sequence of events, and I think it was probably, this is going to sound really lame that I can pinpoint it, but it was the winter of 1986. I was the equivalent of I guess we had junior high then, but a middle school student, and woke up one morning and had right lower quadrant pain. Several hours later, my appendix burst, and I ended up having just an odyssey, a medical odyssey, through no one's fault, of an infected peritoneum, and et cetera, and ended up in the care, in a lot of ways, in my personal primary care physician named James Chu. And he saved my life. I mean, by whisking me away to surgery, and assisting with the surgeon. He was a family medicine doctor, and he assisted with the surgery. And the amount of, not so much what he did, is how he cared for me, and how he cared for me in that subsequent episodes of care and complications, never wavering. I never forgot that. And you may not believe this, but 3 or 4 months later, I fell ill again, although in a very different way. And as a 14-year-old, was diagnosed with Kawasaki disease, which is usually a diagnosis in kids less than 5, and oftentimes in infants. And so it was through his own consultation of a pediatrician, and his own staying up late reading about me, that allowed him to make the right diagnosis and got me into a clinical trial in Northwestern, at Lurie Children's Hospital in Chicago, when it was just known as Children's Memorial. And this guy, pediatric infectious disease doctor, Stan Schulman was his name. He was, a legend in the Kawasaki, lore, as I later found out, and was the world's expert. Enrolled me in a clinical trial, and the whole enterprise sort of saved my life. And so, all of the things that I've done since then with medicine and science have come from that experience, and that formative time. I went on to go to medical school after going to undergraduate at Virginia Tech. I went to medical school at Ohio State, did the MD PhD program, and I became an immunologist as well, probably because of my experience with Kawasaki disease, and being, sort of in a strange niche as a patient. And subsequently did med-peds, probably because of that. But I think the first time that it really came to terms of, this professional identity as a physician, really became real in, like, my 3rd and 4th year of medical school. That's the first time I really understood the benefits of a therapeutic relationship with patients, and truly felt like I was caring for someone in a way that was outside of myself. And so it's been a long odyssey. That's been over 20 years now since I've been out of medical school, and in practice now for about 16, 17 years. So when I reflect back on all of those things, I think it's the only profession for me. I gave up basic science research in the pursuit of being a clinician scientist to be a medical educator. And other than that one large deviation from the original plan, it's pretty much played out the way I thought it would, as far as, like, what it means to be a physician in society, what it means to be as a physician for students and for residents, and the impact that it's had on me as a person.
Did your doctors ever get to know? Like, was your family medicine doc young enough that you were able to write home, "Hey, I made it to med school. Thank you very much"? Or
Yes, I actually have a great backstory, or way to close that story. So I was in touch with Dr. Chu. I was in touch with Dr. Schulman. I have a picture somewhere on my phone of him holding my paper chart decades later. I celebrated grand rounds. I was invited to give grand rounds when I was a resident at UNC Chapel Hill to the Department of Pediatrics, and I shared that experience with him, and it was about the immunopathogenesis of Kawasaki disease. And so I got to take it about as far as you can without like demanding to put it on my CV, probably. And then with my family doctor, I subsequently learned of his passing. And as it turns out, his son, who was maybe about 15 years younger than me, um, we reunited. I used to babysit for him back in Valparaiso, Indiana. His name is Christopher Chu, and he's a faculty member in medicine and pediatrics at Ohio State. So we see each other on a regular basis at national meetings. I'm a podcaster now, and he's part of the Curbsiders podcast. So we have some of those things in common, but we have sort of reconnected on multiple times. It's been one of the more satisfying loops to close that only 3 or 4 people on the planet care about or even know about, which is pretty cool.
But that's the magic, isn't it? I mean, the fact that in this world of billions of people, there is a handful that know you for this one instant. Here's somebody who's had a busted appendix, right? But I'm his doctor, and I take care. It's a being known, and the relationship of having someone that knows you and is there to listen or care. I think there's such a value in that. When I've had to say goodbye to patients because I'm moving from one place or another, they never say, maybe they should. I wish they would. Wow, what an incredible diagnosis, or wow, your treatment regimen. I wish they did. But what I'm really glad that they do is they say, you've been a really great doctor. You really listen, or you're really there. Those are the things that, to your point, you go, yeah, that is what it's about. That identity is about, and if you can catch it right, that somebody remembers you years later or goes into the field because of it. I mean, what a great compliment to Dr. Chu, that the response to the loss of an appendix was the gain of a profession. That's a wonderful thing. So where along the line then were you when William Osler came to you?
Yeah, so I remember that day quite clearly as well. So because I was in the MD PhD program, I was seemingly delayed in medical school. It took me 7.5 or 8 years, but in 1994, as a newer first year medical student, we were divided up into rooms, and we very vaguely had some notion that we were being split into what was going to later be known as societies within the first year class. I was assigned to room 1, which was given the name William Osler Society. There was the Elizabeth Blackwell Society. There were other societies, and I can't remember all the names now, but I was like, okay, who's this person? I have no idea who this is. And they had a very quick nomination and election process, and I was nominated for and elected to be lead or the president of the Osler Society at Ohio State's first year medical school. And I was paired with a faculty guide, and our job was to create a society type atmosphere where we would do service work, but also meet and talk about the experience of first year medical school. Many of us didn't have a vague recollection or a vague notion of what that might look like, but I focused on the leadership parts, or not the leadership parts, but the service parts, and came up with pretty quickly with the idea of having a faculty versus student basketball game. And in those days, email was not that widely available to everyone as it is now, like on phones and things. So I emailed the university president, E. Gordon Gee, who I think is now the president at West Virginia University, but he was at Ohio State, and invited him to be the guest of honor at our basketball event. And he obliged, and he came. So we had a food drive, and that was my first foray as the William Osler leader. Now, I had very little knowledge of who William Osler was, and I don't honestly know. This is going to sound very dated. If we had things like Netscape, and we certainly didn't have a lot of activity with browsers and the ability to search things. And so I actually went to the bookstore and bought a book that I found on the bookshelf about William Osler. It was I actually have a copy of it. It was about his life and about his methodology for living in day-tight compartments and like his
Is
approach to
that Charlie
professional.
Bryan's? Is that?
Yes, I think so. Anyway, it was phenomenal. I should have been more prepared for that question. I apologize.
No, that's
And,
fine.
and
It sounds
so
like Charlie
the
Bryan's.
scales came off my eyes as a first year medical student. I was like, I've been living my life so, sheltered, and like there's so many different ways to think about ways to approach things professionally. It was a fantastic moment for me, and I bought a copy of Equanimitas and that book of essays, and that was probably about it. But I think that stuck. That was enough to stick with me for the first few years. And then later, I guess it was in my second year, we had a history of medicine course, and I can't remember the name of the faculty member, but we talked a lot about Osler and that the spirit around the founding of Johns Hopkins Medical School and how that really was recognized as an inflection point in American medical education, and sort of the founding principles of a school like Ohio State is reflected in the Wexner Report and things like that, and how medical education had evolved into its current form. And so I actually really became interested in medical history too, and the history of medical education at that time, because I just saw friends in the field, many faculty carried this around with them. I think Charles Woolley was at Ohio State then, and I think he was a member of the AOS at some point. And I didn't get a chance to work with him clinically, but we talked. So there were undercurrents of Osleriania, I guess, at Ohio State at the time, that did percolate down to the students. But I held on to many of these things privately, I guess, especially some of the things that I would say aligned with Stoicism, as far as how to respond to things you can't control, and how to respond to situations. The idea that you would never comment negatively about a colleague. A lot of these things that you'll read in some of the writings of Osler, they became almost like second nature to me in a lot of ways. And I didn't understand I guess I didn't understand how Stoicism and some other philosophical schools and other writers had influenced him. But I became aligned with the idea of, although I knew I couldn't be Osler, I wanted to be like the people he wanted to be like, if that makes sense. So aspiring to loftier principles than even when he was writing about, to understand that. So with not a lot of free time on my hands, went through graduate school and then finished medical school. But in my senior year, I was elected into AOA. And that was, we had to come up with a quote that we wanted, sort of a walk-up song as we got on stage. And I actually, I made a slide with the Marcus Aurelius quote about, you must be a promontory to the sea against which the waves will beat. I love that. And I think that's probably the first time I explored some of those more Stoic philosophical tenets. And then that just continued to build episodically, punctuated by, the birth of 3 children and, staying married for 29 years. But I think more recently, probably in the last decade for sure, I've gotten more systematic and more studious about reading more about Osler, studying his life, studying the lives of related physicians, his contemporaries, understanding the context of American medical education at that time, but also getting into some of the things that inspired him. Sir Thomas Browne, for instance, obviously Stoic philosophical, writings and things of that nature. I became, I wouldn't say obsessed with, but excited about the idea of books as instructive in life and in relationships. The Osler bedside library, understanding the importance of the last half hour of the day, really talking about that in public, even when maybe people didn't know where that was coming from. And the idea of making books available through my own personal collection to others, and then also gifting books, has really become something that I feel uh, really good about, and having that be sort of how people can identify me in a friendly way, someone that may be their mentor or guide or confidant.
The books thing, I'm just thinking about one of the first medical books I was ever given by, preceptor. It was a psychiatrist, Dr. Brennan at Spring Harbor in Maine, and that book had been given to him by an ophthalmologist. That was 25 years ago, and he says, "You're really interested in these kind of beautiful cases, so I'm going to give you this book. But once you see somebody else who's also really interested in cases, you have to give it away, you know?" So you've got this hot potato. I've got this hot potato in my hands where I'm like, I really like this book, but I know I have to give it away. So so you're always looking for the part, you're really looking, do they really like cases, or do they just want an honors credit on their, when they, those kinds of things. But I know I have to give it away, and it's a joy because now I see now there'll be 3 names on the flyleaf instead of just 2. It's an exciting part of it. And that's certainly something that at the Osler Society meeting this past year, there was a lot of, here's this book that I bought. And then lo and behold, it's a book that Dr. Bean owned. And like, oh my God, how did that, and you listen to these extraordinary tales of the life of the book. And I when I talk to fellow medical folks, there are those who like the books, and those who are kind of indifferent to it. And I actually think that your comment about being a spot where you can lend, here is a book you might like, read this first, is really important. Dr. Molina, who's on the board right now, he was just asked by somebody, what's the most important thing you do? Now, okay, now you're in medical school. What do you got to do? Okay, if you pass these tests, that's great. Now you're going to go into residency. What should you do every day? Read. It was just read. And your comment about the Dr. Chu saying, I was reading up a lot about this and I was talking with a pediatrician and we figured out what it was. In a world where you couldn't just refer and hope that referral mattered, you were more invested, or you could be more invested. It seemed like you could be more invested.
Yeah, thinking back on that case, he wasn't saying that to brag. I think he was genuinely perplexed. And I actually, he sent me my chart, and in those days the documentation was not super robust, but he did have subjective, objective assessment and plan. And the first couple of days I was sick, he had me come back every day. He didn't know he honestly had like question marks in the blanks. The toxic shock, from a retained infectious element, was what he was thinking. And actually, strangely, that was very reminiscent of some of the symptoms of toxic shock, was what I was going through with the vasculitis. But no, but you're right. And it impressed upon my parents too, that he was really thinking about it and not like trying to show off his knowledge. Because then there was no internet and there was no referral. So there was, he was it. We were in Porter County, Indiana, and there wasn't a lot of resources that he had. So
the latchkey group, that Osler had and started, to your point, it is so much more than just the knowledge, right? If it were just yes, he had an incredible library and how valuable that was, that you could have access to it, but embedded in that is just the trust. Here's a key to my house. I don't know what the equivalent is today. And one of the questions I want to sort of ask you, as you've now moved from a position where you are able to influence educational programming, on a level that's larger than just, here's my ward and I'm on for 2 weeks. What are some of the more kind of eternal, everlasting, evergreen, I guess you'd say, evergreen practices of Osler that you're trying to grow in the trainees that you see?
I think the first thing is, I think about some of the pictures I've seen of Osler, and I think, especially at the bedside, is that he was an excellent physician at the bedside or in the clinic, and that's reflected in patient testimonials, even famous patients who wrote to him. But so I guess I try to impart the idea of being a thoughtful clinician, right? Thoughtful clinician to their patients, servant of the patient, patient-centered, patient first. All of those things that aligns with who I am as a person, but it also, I feel like, aligns with who I project, that that's one of the people that I feel like in history that I got, that's the way you're supposed to comport yourself. The second thing has to do with the latchkey phenomenon, but there is no equivalent to that. I probably live 15, 20 miles from where most of the residents live in Cleveland. And so that is sort of out, but in a way, I have tried to make my home and myself in that vein available to people with still having boundaries, obviously, that are professional. My wife and I and my kids, actually, they're older, but they come back for this now. We have the residents over for Thanksgiving dinner. I mean, we have people from all over the world come to our residency. We only have space for about 25 to 30 people, but we make a good dent in it the last few years by having people over at Thanksgiving. And so that's one small gesture. Bringing in food on Christmas Eve, for instance, that's something that my family does every year, or we try to. It's not just a gesture, it's like actually being present. And then in that same vein, making myself available. I have been guilty of giving out my personal cell phone number and saying, call me anytime. And I mean it. If there's something that's an issue, my chief residents take me up on that. They call me about patient encounters. They certainly call me about difficulties in the residency, and residents feel and they feel like they can trust me to do that with confidence. I do the same thing with all of our first year residents. I send out an email with my cell phone, they text me, we establish a relationship. So I guess that's the second big thing is truly being present for people in a way that has context and sort of in quote unquote this day and age, in that same spirit. And then I guess the third thing that I talk a lot about with trying to have impact is not just on the trainees, but it's amongst my peers too, is to cultivate your professional identity in some way, either through CME or some sort of activity outside of work, that is related to our work as physicians, and not just have like this. It may sound like I'm not a fan of physician well-being or boundaries, but I actually am. But work and life don't have to have these big boundaries between them. It can just be life. And if you're, if you're, I think if you're have things right sized in your mind, you can be a successful physician who's embedded in their life without having to keep things separate between work and life. And that's what I try to embody, hopefully successfully, to those that are sort of coming after me, coming behind.
I'm wondering about, there are some very pressing problems or certainly concepts that are pressing in education, whether it is for the medical students, residents, or even for continuing. People have, on the one hand, there's been imposter syndrome, and this was a term that is now a term du jour. I mean, it's everywhere. Everyone talking about it. The other is burnout. And, obviously there are systems level reasons. I mean, you were talking about cultivating a professional identity, and I wondered to what extent that's actually curative to a system problem where referrals are no longer made to the individual doctor, but are made to a division, right? I'm referring you to movement. Well, you can't. There is no motion in movement. Movement is an abstract field. You're referring to me to, Dr. Alice Flaherty of the movement. And so to what extent are systems and the way they operate are dehumanizing in and of themselves? And so you've got a really good curative approach to sort of say, well, this is that. In the areas you have control of your identity, make it shine, make it polish, make it legit. I'm wondering to what extent when your colleagues come to you and they say like, wow, I'm really feeling this thing called burnout. I didn't understand what it was, but now I know what it is. Or imposter syndrome, like, oh, I didn't realize that's what this is, but that's what I feel like. Are there some sort of Oslerian paradigms that you might rely on, or things that you've picked up on that are of a humanistic approach?
Yeah, there are actually, and I try to have tonics in mind, understanding that I don't understand everyone's experience. And I'll just be honest. I mean, as a medical educator and as a 52-year-old father of three, married almost 30 years, like burnout is real. I mean, I've experienced it myself in retrospect and sometimes in the moment. And I'm not saying it's like, oh, I'm feeling bad today, I'm burned out. I've had long stretches actually of difficult times. And what got me through that though, was my desire to continue to be a physician and to be an effective physician. And I wouldn't say that I pointed to a specific Oslerian reading, but there is that philosophy I think it's really reflected in one of the graduation speeches, a way of life. That's a really good pep talk for me. I mean, I give that away to the residents. I've talked about it and publicly as a way to approach days. And it's not a cure-all, and it's not a panacea for systemic problems. And so I think as physicians, we have to have a healthy disrespect for the system, and we have to have a healthy disrespect for the leaders within that system before we go blaming ourselves about our lack of resiliency. I'm a big Tate Shanafeld follower too. I'll be interested to see, him and his those that have come after him, and Colin West, for instance, at Mayo, and how they've addressed some of the systematic burnout issues, is to really de-emphasize the importance of resilience and re-emphasize the importance of good leadership and systemic culture. So to just put it fully on Osler to be able to, Osler our way out of the burnout epidemic, I think is probably asking too much, but it does help me, and it has helped assuage my own insecurities in many ways around the imposter phenomenon, for instance. And it goes back to like this meditative practice of centering, having routine, not having chaos, the day type compartment. I have a picture of him, writing at his desk when he was writing the Principles and Practice of Medicine. He would do that in the morning, then he'd go around, and then he would go to his clinic. And he did that every day. I assume he wore the same outfit too, so he didn't have to overburden himself with
Sartorial selection.
yeah, yeah. So I mean, but those are things that are useful for all of us. If you're in a chaotic practice, make it less chaotic if you can. Exert whatever control. And so for the residents, I understand that they have much less control over their schedules and out over there. So it's my job to mirror, for instance, what a good learning environment is, what a good clinical learning environment is, and all the parts that go into that. So I hope that answers your question. But no, burnout is real. There's no one or two things you can do to fix it. It's a systemic issue. It's a leadership issue. It's definitely, there's cultural underpinnings, and there are individual things that can help. And for me, it's a steady diet of self-reflection, living one day and not ruining the next, and not having too dim view of the past either. And I think a lot of that is born out right out of some of the writings that we've talked about. And I find that reassuring and a nice place to go back and visit on a regular basis. And when I share that with others, that usually leads them with some better perspective.
Well, the practices that you mentioned, like Osler's shelf. This is the shelf for medical student. Regardless of what is on the shelf, as long as it's good, capital G. Doesn't matter which one it particularly is, and every so often you get a new article in the Green Journal or whatever saying this is this decade's shelf.
Yeah.
But I think that point being is, if you give yourself half an hour a day or 15 minutes a day, that's actually really important for you uh, as a human being. I think particularly as we as physicians are no longer making house calls, no longer living in the communities and neighborhoods in which their offices was placed, it's harder to get to know your patient. And books are an incredible way to get to know a world that otherwise you wouldn't, so that you can be ready for these types that these that walk in. His line about spending time with the saints of humanity, right? Sort of like that. You've made some comments about believing certain things or practicing certain things, but not being public about it. And to what extent that was just because, well, you didn't have a venue for it. I mean, when you're a resident, there's no real great need to be sort of thumping with equanimitas, right? Whereas now you're like, I got the space, I can do it. How much of it is that versus did you feel, or do you feel, and if so, why, there's a pause when people want to talk about history or humanities or philosophy in a great humanities or philosophy in a way that they don't when we're talking about great science. Did you read this
Oh,
great
yeah.
science book, as opposed to going, did you read Michael Bliss's William Osler?
Yeah, it's all about for me, it's about the context and the crowd, and to your point, one of the first things I did as a medical educator when I was at UNC Chapel Hill, when I took over the Med-Peds program, you may think this is corny and really obsequious to this interview, but one of the first things I did is I introduced an Equanimitas Award, because I finally had the venue to be able to share how this made me feel and what the import of this kind of award can do to recognize these behaviors, which we think are positive. And so it may seem like a small thing, but it ended up being like a defining moment for me to be able to have some of these things. I can now talk about this in a way that I'm confident and I know that it will have impact. Did the same thing at Cleveland Clinic. We have an Equanimitas Award now. And so for anybody who's watching me longitudinally, is like, oh, he just keeps doing the same 5 things over and again. But that's
Johnny
okay because
Appleseeding this, which is
yeah,
a
so I
great
think
idea.
that, hopefully we're continuing to press on with that legacy in a meaningful way. But I think to answer your point, I think people feel less confident in talking about medical humanities because they're either unsure of themselves or they feel that they'll be judged. I'm still going back to thinking about how I felt about my medical humanities course in Ohio State. It was actually done quite well, and I feel like it was before its time. But the students hated it because it wasn't science and they didn't feel like they were progressing. And they made fun of it. And I can remember one of my classmates getting called into this Dean of Student Affairs office because of his handling of the essay questions. He made a mockery of it, and they didn't like that. So I think there's still some underpinnings of this isn't hard science. This isn't. I don't see the role. We've done some things in the residency here with narrative medicine, and teaching quote unquote the soft sciences, social sciences, but it totally impacts patient care, and it impacts our ability to give patient care. I feel like if it addresses our underlying humanity. So without trying to justify too much, I think people feel uncomfortable because it's still like viewed in medical education as maybe being soft in a lot of ways. Because it's so easy to go back to the facts and the science and the p-value and things of that nature to say whether something's worthwhile or not. I'm probably more comfortable now because I live in the medical education space where it's more about impact and less about p-values, and it's more about the long haul than it is about a specific study or something like that. So I hope that answers your question. But I think the more space we create for this dialogue, the more richer discussions we'll have. And that's what we've tried to do here more recently. There's a Hemingway story that I really like. It's called A Day's Wait. I don't know if
I
you've
don't
ever
know.
read
No, I
that.
don't know that one.
Yeah, but it's really fantastic. And so that was one of our required readings in our narrative medicine course. And it's all about a child who misreads or misunderstands the temperature on a centigrade and Fahrenheit, and so they assume that they're dying because their temperature is 40 degrees. Um, uh, and I'm sorry, their temperature is 104 and they assume that 38 is normal because they're used to centigrade. And so the confusion that ensues for this 5-year-old is, I think the child is 5, is really dramatic and leads to the tension in the very, very short story. It's like 3 pages long. But in so doing, Hemingway captures everything that we need to know about patients and prognosis.
A p-value can tell you if something is significant, but it's the doctor and the patient that can tell you if it's valuable, if it matters, right? Because medicine is fundamentally a moral science, right? It's a normative science. And so it's like navigation. You can know everything you want about meteorology, but that's not actually going to get you from harbor to harbor. Similarly, I think, it's that humanities element, which is what teaches us an axiology. And what I've come to learn through my time with the Osler Society is like you get from the not just from the presentations or from the articles in the newsletter, but from the people, from the membership. You get this feeling or this texture of a current. A current is probably a better one because there's a directional element to it of like, oh, this is doctoring. I can feel like this is the effect of like, here's 30 years of doctoring. And this is like how this person approaches like the sandwich that we're going to have. I mean, it's little things like that, but you go like, oh, I can see it's a gravity that doesn't bring you down, if that makes any sense. And that's, I think, what good doctoring has, or that identity that you're talking about. In the last kind of couple of minutes, I wanted to ask you, how you are expecting or hoping to use some of your time in the AOS, in the American Osler Society, because there's a lot to do and there's a lot of heavy lifting, and we'd love to have you in any of it.
So I'm at your service. So part of being new to any organization is being curious and being in an exploratory mode. First of all, I just want to say I'm delighted to have found out about the American Osler Society in an official capacity. And it had been on my to-do list for several years to look into membership. And so when I finally, those neurons aligned and circled and fired, I was very delighted to be able to apply and be selected. So that's first off. And second, my hope as a medical educator is to contribute to the legacy of Osler through demonstration, but also engagement with students and residents. I know that there are students and residents everywhere that could benefit from this, but specifically in my own neighborhood, making this a part of our large residency program, and making it sort of part of the dialogue. But then in that regard, I'm also very interested in I guess I would say the amateur skills that I have as a writer. I know that there's a lot to be explored here, not just from a historical perspective, but on a prospective process about where we're going. And so, with my role at the ABIM, for instance, I'm really fascinated in doing some sort of simulated expertise evaluation of like how Osler would feel about maintenance and certification, for instance, in the current context. And without getting political on one side or the other, I think it would be really fascinating to sort of do some sort of in-person session, like a trial almost, and have, Osler be on one side or maybe even the judge. So I think that there's some really fun stuff that can be done to bring some of these musings to light. I'm also really fascinated with just learning and being a part of the membership too. I got my membership certificate over the weekend, and it was like, believe it or not, it's actually one of the cooler things that I can imagine at this point in my life is being a member of this organization. But I want to be able to go to the meetings and participate, learn, and hopefully someday contribute. I've given some regional and national talks on Osleriania, but without being an expert. And I would like to continue to try to develop those for the betterment of our profession.
And one of the things you'll find from the talks that I enjoy is that the Q&A could be just as long as the presentation itself, because you set one of these members off and they got something to tell you, and then this is all that reminds you, and it's like watching a mousetrap go across the room. And you go, wow, at the end of this, if somebody was keeping track, we would have had another article, And many of these talks do go on to be books. And that's again also a very kind of fun thing, is you get to you see on the newsletter where so and so's got a new book out, and you go, I remember when that was a talk 2 years ago, in Montreal. So there's a great joy in that. I think what I would hope that you'll be able to take your skills is your great understanding of leadership as it pertains to societies, and also your great enthusiasm for the inclusion of trainees and junior members, and saying, how do I show that what appears to be as only a before, which is kind of, I think, what a lot of people will look at history and say, well, this is all chronology. I think there's a great misunderstanding that history is not chronology. It's not knowing the date. That's a fun part, and it's good to know the date, right? But it's the themes and the lessons and why it still matters, to us, and that kind of before and after, like you were talking about reading the Ernest Hemingway short story and saying, well, what does Hemingway have to do with medicine, right? And you're going, here's a great example of if you let that, if you let that story go among a couple of residents and you just get them to go as a projective test, and they're going to learn something about how they feel about themselves and how they feel about their profession. And that's where real growth and development can begin, where you've said it out loud and you realize, you go, oh, I didn't know that's how I felt about it, uh, and practical jokes, because I don't think there are enough practical jokes. And William Osler was a great practical joker. But so wonderful. So anything that's on your shelf or in the future that's coming down the pike for kind of history, humanities, philosophy, and medicine? Is there a project you're you're itching at that you're hoping to get to?
So there are, without being too well, I'm happy to be granular. I'm on the editorial board for the Hospitalist, which is a magazine that supports Society of Hospital Medicine, and I would love to have a series of articles written by a hospitalist about their reflections on Osler potentially.
Hmm.
That's one idea. Also, I would love to do a position piece or at least some sort of hypothesis-driven exploration about whether Osler could be considered a hospitalist by today's standards, given the percentage of time that we know he practiced in the hospital. As you know, there are many academic hospitalists. And so everybody wants to claim Osler, but I would love to explore very superficially his role as a hospitalist. I think I claim him when I've given talks before. So he's like us. Like he got up in the morning, he did some work, he rounded, and then he went about his day. So
Well, yeah, I guess the question you always
those
ask
are
is, you
just a
say,
few.
is founding a hospital good enough to say that's what makes you a hospitalist, or? But wonderful. Well, I mean, this is we are well. You heard it here first, folks. If you are interested in submitting Oslerian to the hospitalist, it'll at least be considered. We'd love to have it. And Dick, we'd love to have more of kind of your participation in the society, whether it's presentations, whether it's reading groups. One of the big things we're trying to do is certainly make sure that disparate young Oslerians don't get lost out there in some sort of, Atlantic that happens. We're hoping that there'll be some kind of Sargasso Sea for them to come to every once in a while and remember, like, oh yeah, this is why I did this, and medicine, this is what medicine's about. We've got a few Johnsonians like Jock Murray and myself who really like Samuel Johnson's poem about his one of his boarders, Dr. Levitt. That poem is a great balance between greatness and littleness. And Johnson was obsessed with I mean, different scales. You talked about Fahrenheit and Celsius, and this notion of like any human being at any given moment can be classified under half a dozen different scales and axes. And indeed, our patients are the same way, depending on, if the renal doctor looks at him, he's on a stage of kidney function. And if the heart doctor looks at him, he's a stage of heart failure, the cancer. But what is the measure of this man that's in front of me? And the answer, that's for the doctor, globally, to sort of balance these various scales and say, what is just right? What is good? How do I get him closer to goodness, accuracy over precision? And so I think a lot of what you talked about and what you try to engender in your students and colleagues speak to that. But yeah, I would add Johnson's poem about Dr. Levitt. It's a cute little poem about greatness in small things, in little, which I think at a day where so much of what we do as a profession to try to survive academically is how can I make the biggest noise and how can I be the biggest name and the other, the strength about just being good, which is I think what Osler is most remarkable about, is he just was good. And if you're just good, it's remarkable. And that's true at any age. So Dick, one of the questions that comes to mind for a man like Osler, who was given to many different aphorisms, always had a good line, a good statement, something pithy that you could live by and work with or offer to a patient. I'm thinking about the ones that we have and where to find them. Obviously, the classic one that I lean on a lot, which is, of course, the difference between what we're treating, right? Which is that Osler had mentioned that a good physician treats the disease, right? But the great physician treats the patient who has the disease. And it's a reminder that I've often given to a lot of our students or residents when we're all down the minutia of saying, well, I can drug this, and then to sort of affect the side effect of that drug, I can give another drug. And now I'm 3 drugs into affecting 3 side effects, and you're going, wait a second, what am I treating? And the answer is not what am I treating, it's who am I treating. So I like Osler's line about the good physician treats the disease and the great physician treats the patient who has the disease. So I'm wondering, are there ever any of his kind of bon mots that are available to you, you know?
It's hard to pick a favorite because there are so many. In fact, that's one of my favorite little books to carry around is aphorisms. I think if I had to narrow it down, I would go back to the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. That's probably my favorite, although I could be convinced of some of the others about teaching students and practicing without patients or, like learning without patients, for instance. But that's my go-to.
And my little, my little go-to reading list is there's Osler for White Coat Pockets. That's the one that I like. That's also, I think that's downloadable for free actually on the American Osler website as a PDF. But that has done a really nice way of integrating the Oslerian comments and commentary from his books and his sayings, and actually integrating it with very practical matters for a medical student. So it used to be I would give the one that's like, oh, here's the collection of epitaphs, the Fielding did or such and such, and now it's like this is the one that you can actually put in your white coat pocket. So I do recommend that. If you're not going to go through the 2 volumes of Cushing's biography, and underline them yourself. If you want them already curated, that's a good one to go to. One of the things that you mentioned was the podcast that you manage, that you host. And so I was wondering if people want to find out more about kind of what you're doing, what are you up to, the organizations that you're helping, and the projects that you're working on. What's the best way to follow or find you?
Yeah, I'm happy to share that. So, if you go on our Cleveland Clinic website, you're not going to see a lot updated, but we do have a podcast that is funded through the Education Institute here. It's called the Medicine Grand Rounders. I'm happy to talk a little bit about what that title means in a different venue, but it's essentially our dedication to Grand Rounds and our residency, and we have a podcast that gives you what we consider to be Grand Rounds level content in less time without having to be there in person. It's through the discussion. It involves trainees, it involves clinical experts. I think we're in episode 13, 14 at this point. Really excited about that. I am on X, formerly known as Twitter, is MUDFUD or MUD_FUD, giving a shout out to my MD PhD heritage. I share a lot of medical education content, not a lot of personal content, but some as it relates to professional home, work in the ABIM, work with ACP, work with AIM, etc. But really as a platform for use it mostly to encourage and sort of exemplify all that our residents are doing. We also have a residency Twitter called CCF IM Chiefs for Cleveland Clinic Foundation IM Chiefs. And then of course I'm on LinkedIn. I've gotten away from other forms of social media, have not explored TikTok and things of that nature. So those are the primary ways.
That would be an interesting, it's not the question of would William Osler be on TikTok. It's what would a William Osler TikTok look like? It'd be very interesting to see what the practice of medicine would have looked like on that. Well, awesome. Well, we will make sure that we include the relevant links so that people can find you. When they finish this interview, and they go, "Oh, I need to find him on Twitter or X or whatnot, or the podcast." So thank you so much for your time today, and we're looking forward to seeing you at the events. And please write something for the Oslerian or the blog. We'd love to have it.
All right, thank you very much, and thanks for the opportunity to sit and talk with you. It's delightful. Whenever you meet someone over distance and time, and then you really hit it off, it shows. I could probably talk to you for another hour. So I know that the listeners don't want that, but I really appreciate the opportunity to explore this space with you.